Okay, thank you, Dr. Mahoney, for joining us. Just for the parents, we have Dr. Derek Mahoney here, who's out of Australia. It's May 20th, 2015. So thanks for joining us, Dr. Mahoney. If you could please let the parents know a little bit about yourself, that'd be great. Then we'll go into the questions.
Well, thanks very much for asking me to talk on this channel.
Thank you.
My background, I'm a specialist orthodontist. I'm based here in Sydney, but I did my initial training in London. And my training in London was very didactic orthodontic training, where pretty much we were taught how to move teeth, but there wasn't much attention paid to the facial balance or the health of the jaw joint, and certainly nothing on the airway. And what I've found over 25 years in practice is that many of the children that I treated in my initial philosophy of training ended up having flatter faces, having more airway issues after their orthodontics. And so I went on a pathway or a search for new ideas, and I was lucky enough to come across some of the opinion leaders such as Dr. John Mew, who had a different philosophy in orthodontics, and that's a philosophy that I've been using for the last 15 years in practice, and I'm hoping I can share some of that with the audience today.
Excellent, thank you. So I guess could you tell us a little bit about your philosophy and how you practice, and what's the most important thing to you when you treat a kid?
So my practice is called full face orthodontics for a reason. I think it's more important to have a nice balanced face than necessary to have straight teeth. And if you look at some of the writings by some of the very famous orthodontists in textbooks, there's quotes such as to ruin a face at the expense of an ideal occlusion, which is an ideal bite, is not necessarily the greatest standard of care. And what I do now is I will look in the first instance at the upper jaw. And the upper jaw needs to be a certain size to accommodate the teeth, but more importantly, it needs to be in a certain position to balance the face and to open up the airway. And unfortunately, in the past, in the way I was trained in orthodontics, everything was viewed as a dental problem. So we have a thing called Class 2, which is the most common malocclusion in the world. Class 2 means that if I can show it with my hands, the upper jaw and the lower jaw don't meet. And in the past, we would view this as a dental problem where the front teeth stick out. So our treatment would be to extract teeth, maybe use headgear, maybe both, and pull the upper teeth back to meet the lower jaw. Now our philosophy is to leave the upper jaw in its correct position if it is there, widen it and accommodate room for the lower jaw to come forward. And this is much better for the child's airway, for their facial balance, for the health of their jaw joint. It also makes the time that they're in orthodontics, as in fixed braces, of a much shorter duration. So to me, this is definitely the modern principles of orthodontic care.
And is this now pretty widespread, would you say, or is there still a lot of retractive orthodontics happening?
I still think there's too much retractive orthodontics happening, but again, that's a very broad question depending on which part of the world you're talking about. Some areas are very progressive. I think in Europe, the philosophy to get in early on children, develop the arches, minimize extractions is a lot stronger than it is, say, in the United States or where I practice here in Australia. But again, that's not to say that everyone is still doing the traditional orthodontics. There's a lot of progressive orthodontists there that are doing the right things. And I'm not blaming people who are doing the wrong thing as necessarily intentionally doing the wrong thing. They're doing what they've been trained to do, and maybe they haven't been exposed to some of this newer philosophy.
Yeah. Okay. What we've heard of orthodontists doing, like extractions in every case, right? They see an upper jaw with crowded teeth, and they say to the parent, "We're going to have to remove four bicuspids, and pull teeth back." What are your thoughts about that, and what are some of the alternatives that parents should know about?
So when I trained in the traditional model, whether we extracted teeth or not was based on the millimeters of crowding and also the angulation of the teeth relative to an x-ray called the lateral ceph, which is a side view of the skull.
Yeah.
What we now realize with modern technology, such as light force brackets, such as light force expanders, we can actually make room for the teeth that in the past we would extract because there was no room. The other thing in the modern philosophy, and I guess sort of a quote could be, we now extract for the face, not for the space. What does that mean? I still would extract in some patients who are overly full, meaning their upper jaw is too far forward and their teeth are much far forward than they need to be. These patients can't get their lips together and the angulation of their teeth really stick out. And it's very common, say, in Chinese patients, say in African norms, etc. But for the majority of, say, Caucasian patients, the opposite is true. So I would say my extraction rate, which when I graduated was maybe 85%, is now less than 5%, and that's based on the facial profile, not on the crowding. So I've changed my parameters of diagnosis to look at the face, to look at the airway, to look at what impact what I would do would have on the face as it ages, as compared to purely looking at numbers on a cephalmetric radiograph and millimeters of crowding on a study model.
Mm-hmm. You were on 60 Minutes a few years back.
Correct, yeah.
Could you tell us a little bit about that and what your message was?
So the 60 Minutes interview was really an interview to suggest to parents that maybe there's an alternative of care. And I think it made a big impact here in Australia, and I've had emails from parents all around the world as a result of that going on air, that they didn't realise what were the negative consequences of some type of orthodontic care. Mm-hmm. Also on that interview was Dr. John Mew, who talked about his twin studies, which was a great study looking at identical twins who had two different types of orthodontic care and looking at the impact that different care had on the child's face. And I would, like any parent who is still unsure or maybe wants to get a second opinion, to watch that documentary, and also to look at certain websites. There's a face focus group by Dr. Bill Hang, who's an orthodontist in California. There's Dr. John Mew's School of Orthotropics. There's a lot out there. There's also a website. It's called damagefaces.com. It's a chat room where a lot of parents who've had the treatment for their child or for themselves have been unhappy and just trying to educate other people. But as I said, everything you see on the internet may not be taken as gospel, but at least it allows a parent who might have some area of concern to warrant a second opinion, to seek that second opinion and then make their own judgment call on what they think is better for their child.
Okay, so if an orthodontist is doing extractions and they're not looking at the airway, could they possibly reduce the tongue space and cause the tongue to deviate backwards into the airway?
Yes, so the tongue space is based on a number of factors,
okay,
but certainly the width of the upper jaw is important. The second thing is the position of the upper jaw. So when we talk about airway, we're talking about upper respiratory airway problems such as deviated nasal septum, enlarged inferior turbinates, large adenoids. But what we're talking about in the orthodontic sphere is the area at the back of the upper jaw, the area at the back of the maxilla, the soft palate, etc. And again, if the maxilla is pushed backward, that area becomes encroached. The second thing is if the upper jaw is pushed backward, then naturally the lower jaw has to be pushed backward. And that's where the tongue lies. So again, what we see in a lot of adults now who've had the traditional orthodontics is a high incidence of snoring and a high incidence of sleep apnea because of that tongue space encroaching over the back of their airway, what we call the oropharyngeal airway space. Mm-hmm. So when I look at a patient now, I don't just look at their teeth to see if they're crooked or not. I look at the width of their jaw, and I also look at their tongue to see when they say the word "ah," what is their space at the back of the mouth, what we call the Mallampati index. If the tongue has scalloping on the side of the tongue, that's normally a sign that the jaw size is too narrow to accommodate the tongue, so the tongue is effectively splinting. And I work a lot with nose and throat doctors who use a nasal endoscope to evaluate the airway for my children. I use technology such as CBCT, which maps out in 3 dimension the child's airway. And I've got thousands of patients I've treated early that I can demonstrate an improvement in their airway in what I've done now, which is developing of the jaws and bringing the jaws forward, compared to what I used to do, which was retracting the teeth and making the jaws narrower. So there's a lot of evidence out there to support what we're saying. Mm-hmm. But again, Each case is a decision by decision basis based
Yeah.
on the records taken for that particular child.
Okay. So let's say a parent goes to an orthodontist and they ask the orthodontist, "Are you going to be working with an ear, nose, and throat doctor to look at my kid's airway?" The orthodontist says, "No, we're not." The parent then says, "Okay, are you extracting teeth? Or are you using headgear? Or are you in any way reducing the tongue space?" The ortho says, "Well, we're going to extract teeth, we're going to use headgear, but the tongue space will be just fine, the airway will be just fine, don't worry." What does that parent do? Do they go look for another orthodontist who's going to work with an ENT? Do they go get a second opinion with an orthodontist who's going to talk about expanding? What are their
I, I
options?
always I always encourage, even for my own patients, if they have a doubt, to get a second opinion. I also encourage parents to look at what's available for them and compare, because you can always take teeth out later if the decision was incorrect, but you can't put teeth back in the head. And one of the great things on that website, facefocus.com, it shows a number of adults who've been retreated many years after orthodontics by pushing everything back forward and reopening those four spaces to put implants in, which is a lot to go through for anyone. Again, a modern day orthodontist would be using technology where they can show the parents and they can demonstrate to the parents where the current child's airway currently is. And if the airway is fine, then maybe there's less a concern. But a lot of these patients who have crowding, by and large, also have narrow jaws and by and large also have compromised airways. So the sort of orthodontist I would suggest a parent would want to see
Yeah.
with someone who has newer technology such as CBCT, and from that CBCT x-ray can demonstrate what's called the MCA, which is the minimal cross surface area off the airway, and can show that to a parent. There's lots of softwares. One which is great is called Anatomage, which focuses on looking at the airway in children from that initial orthodontic x-ray. That's the sort of patient that I'd be sort of comfortable working with. There's lots of techniques in orthodontics, as you can imagine, and there's different types of braces, but straightening the teeth is no longer the important thing. Getting the airway improved, getting the face balance, getting less pressure on the jaw joint, these are all the things that are really more beneficial than just straight teeth.
Okay, two things. One is, when does the face finish widening? Is there a normal age where growth is 100% done?
So the ideal age, if we're going to do the type of work we're doing, is between 7 to 9.
Yeah.
Because that's when you're getting maximum growth of the jaws. As far as the maximum age, even in a non-growing individual, you can still do some expansion, but the expansion has to be done with much lighter forces, and you're not taking advantage of remaining growth. Great research done back in the 60s by an orthodontist named Dr. Robert Ricketts. He looked at facial growth from children from birth right through to adolescence. And what he showed in that the majority of children by age 9, the 80 to 90% of their facial growth is complete. And parents find that really hard to comprehend because many parents equate facial growth with standing height. And what I say to parents is the two are totally different. When you have a baby and the baby's born, the head is much larger than the body. And there's a reason for that, because craniofacially, growth occurs much sooner and finishes much earlier than standing height. So even if your child is much shorter than their mother or father, if they're still changing shoe sizes, that means they're still going to grow in height, but it doesn't necessarily mean that their face is going to grow. And one of the things we look at on these new x-rays is what's called cervical vertebrae. And the cervical vertebrae of the neck give us a very good indication on how much facial growth is remaining. And again, new research on cervical vertebrae confirms what Dr. Ricketts had said many years ago, and that is upper age of 10 is when most of that facial growth, particularly with the maxilla, is complete. So if you're worried about when to take your child to an orthodontist, the ideal age is 7 to 9. Any later than that, already you may be missing the boat when it comes to facial growth and development.
Okay. And how old is someone when their face is 100% done growing, like to the micron?
I don't think anyone's face ever stops growing. That's
Okay.
like saying, when is a person really dead? I think a person is really dead when they're not breathing anymore.
Yeah.
Okay? There's been research to show that even in adults,
Yeah.
there's potential to remodel sutures.
Got it.
And as a result, if I have an adult who doesn't want orthodontic surgery but would like to have some improvement, then I use appliances such as an appliance called the DNA appliance developed by Dr. David Singh. There's an appliance called a Homeoblock developed by Dr. Ted Belfour. There's the ALF or the ALF appliance by Dr. Derek Nordstrom. All these very light force appliances I've used in adults routinely without getting all the damage we used to get with rapid expansion. See, with kids you can do rapid expansion because the jaw's still growing. With adults, you have to do very slow expansion because if you don't, you run the risk of causing gum recession, teeth being pushed out of the bone, etc. But that's not to say you can't still do development in adults. You just have to do it in a different fashion. But I think the point is, if you're an adult and you've had the older style orthodontics, it's not too late to try and reverse some of that.
Okay.
The second point I'm making, and the more important point, and that is don't wait till your child is non-growing and go to the orthodontist.
Got it.
When I would train, we were taught the ideal age for orthodontics was 12 to 13 because that's when a child had all their adult teeth, including what's called the second molar or the 12-year-old molar. What I now realize at that age, it's very hard to do the orthopedics that we can do. The face has stopped growing. You're not going to work with facial growth and development. One of the best research ever done and one of the best textbooks ever published, I feel, in this field was by Dr. Donald Enloe. And he calls it Essentials of Facial Growth. And again, he talks about not just teeth, but about how the upper jaw grows. And the upper jaw grows via a process known as intramembranous ossification, which means you need to have a patent airway for the upper jaw to grow normally. And you have to have the tongue in the right position and a normal swallow. So if your child is a mouth breather, if your child has an aberrant tongue swallowing pattern or a tongue thrust, they're not going to grow a nice looking facial balance. And they're the kids that really need the early attention.
Okay. What rate of expansion would you give in an adult if you're using a DNA or a homeoblock or an ALF? Is there millimeters per month?
This research was done by Dr. John Mew.
Yeah.
And Mew divides his expansion into three types. A rapid expansion, which you can do in kids, semi-rapid, which you do in teenagers, and slow expansion. Slow expansion is a millimeter a month, so it's very light forces. Rapid expansion could be 1 millimeter every 2 to 3 days. And semi-rapid expansion is 1 millimeter every 2 weeks, or what we say in Australia, every fortnight.
Got it.
So again, it's not the appliance so much, it's the rate of expansion. And these are some terms that get mixed up. People say, my son is getting a rapid expander, but really, he's getting an expander, he's getting a Hyrax. The way you turn it makes it a rapid expander or not.
I see, it's the rate.
So the term RME is actually a very erroneous term because RME is not an appliance. The appliance is known as an expander or a Hyrax. The rate of expansion makes it an SME or an RME, or if you're doing surgery in an adult, a SARPE, a surgically assisted rapid palatal expansion. So these are what confusing. And I'd like parents to look at a website that was developed by a colleague of mine who's a retired orthodontist, Dr. Clapper. And Lewis Clapper has developed a very good screw, and it's called a super screw. And all the research on that, it gives you the right expansion and it gives you the orthopedic effect. And his website is called www.superspringsuperscrew.com.
Okay.
Or you can Google Lewis Clapper. And there's pages and pages of information there written for parents so they have an understanding of what is expansion, why it's important, what age can you do it, when do you get the maximum benefit from it. Really, really good information on that website.
Okay, 3 more questions. I know you got patients to go see. So first one is for those adults who don't want to have the maxillomandibular surgery, but they want to bring both their jaws forward.
Right.
What would you recommend?
So the ideal treatment still for an adult who wants to have their upper and lower jaw brought forward to open up their airway is known as a BIMAX surgery. And it's a big deal surgery, but the research on it has shown very, very good success. If a patient comes to me and says, Doctor, I really don't want the surgery, I would ask them to sign a consent so they understand that is still standard of care. However, I would offer them alternatives such as these lighter expanders. There's a newer technique using sagittal appliances to move the teeth forward, and using lighter forces on those sutures like I talked about. And that appliance is called a CDA appliance. And a CDA appliance I've used in many adults, and it really pushes things forward. Maybe not to the extent or the accuracy surgery would, but certainly far better when they are now. And what I say to adults, you've got nothing to lose by trying this. If it improves your airway, stops you snoring, helps your jaw joint, you're happy about yourself, etc., then you don't need the surgery. And plan B, if this is not what you're after and you really want the 100% success, we can always entertain surgery at a later date. But I don't rule out to adults like I used to in the past. If an adult came to me 35 years old, had previous orthodontics, I'd say, I'm sorry, you've missed the boat. It's either surgery or nothing. Now I do offer them alternatives because I do understand more about these lighter forces that we can employ.
Can someone use an ALF to widen the face after they do the surgery?
They can, and then many times even after surgery, to improve stability, I'm using something like a homeoblock or a DNA appliance as a retainer. I call it an active retainer.
Okay.
So I'm still keeping those sutures remodeling.
Wow. Okay, that brings me to the question about retainers. The reason I asked you about when growth is stopped is because I see kids who are like 14, 15 years old, and they're put in these fixed width upper and lower retainers, and in my head I'm thinking, this kid's face is still widening, the jaws are still widening, and that is going to help the airway widen, but how can they widen in a fixed width retainer? And so my question to you is, what do you say about that?
Yeah, so I feel that fixed retainers are sort of born of necessity rather than what is ideal. What do I mean by that? The ideal retainer would be a removable retainer, but the problem we've had as orthodontists is children don't wear those retainers. Then their teeth move as their jaw continues to grow, and then the parents get all upset, why do we pay all this money and now the teeth aren't straight, right?
Right.
So the ideal retainer is definitely a removable retainer. In fact, a removable retainer that has a split down the palate so you can still get that remodeling occurring, right? That's what I would suggest. But the reality of the problem is that many parents don't want to take responsibility of their child wearing the retainer. So we as orthodontists sometimes do fix in these retainers, but unfortunately that only keeps the teeth straight. And like you said, it doesn't necessarily work with normal face. Having said that, I've had patients who I put retainers in, and we've taken cephalometric radiographs following them up to check their wisdom teeth, etc. And we found that there still has been forward growth of the jaw. So I wouldn't say it totally stops the growth because remember, it's not splitting the whole maxilla together. It's mainly just keeping the anterior teeth together. But I wouldn't do that for a young child. So a child who still has baby teeth, we wouldn't have those fixed retainers. We're talking more about a post-adolescent, end-of-treatment type patient for that. Yeah.
Okay. So if a kid is sleeping and they've got this, even when they're wearing it when they're sleeping, and say they're trying to grow in their sleep, and the face can't widen, are there consequences to the airway?
See, that's a good question, and I don't think anyone has really researched that particular topic. That would be a great topic for someone to do a research project on.
Okay.
But the point is, by the time we get these kids in the retainers, as I said, facial growth is maximized. Meaning, yes, there's late growth, but not so much as going to influence airway, in my belief.
Okay.
But that would be a good, interesting research project to look at.
Okay. Last thing I'd like to I guess get across to parents is the severity of sleep apnea and how much it can destroy a person's life, and therefore how important good orthodontic treatment is, and making a wise choice in regards to accepting headgear or accepting extractions or accepting anything that pulls tongue space and airway space backwards. So what do parents need to know about the dangers of sleep apnea?
Well, sleep apnea in children is kind of different to adults. So, for instance, the way we diagnose sleep apnea is via a sleep study, and there's a figure known as a AHI, which is the number of apneas and hypopneas you're getting per hour. Apnea is when you totally stop breathing. Hypopnea is cessation of breathing, but not a total cessation. And the number of apneas and hypopneas added together gives us an index of how severe problems are. So just to give you an idea, normal for an adult male is 7 episodes per hour, but for a child it's 0. So that's why it's really, really important that a child should never snore. The second thing is that when you look at the treatment for adults, you're already on the back foot. So if an adult has sleep apnea, they either need BiMAX surgery, they either need a CPAP machine, they need a mandibular translation appliance, which is not a permanent fix because it's only holding the jaw forward at night. Whereas when you do early orthodontic treatment for a child, you're actually minimizing or sometimes preventing that OSA from occurring later in life. Why? Because you're developing the jaw, bringing it forward with natural growth without surgery. You're allowing the lower jaw to grow forward naturally. And children who have problems associated with sleep apnea, it really affects not just their sleep, but their attention in class. There's lots of research papers to show that children who are diagnosed with attention deficit disorder really have sleep disordered breathing. And if you fix their airway, their ADHD improves on itself. So there's attention of your child in class, their development, their cognitive awareness. We know that there's different cycles of sleep. And deep sleep, refreshing sleep, is third stage non-rapid eye movement. To get to that sleep, you need to have a patent airway. So a child might sleep for 10, 12 hours, but still not get refreshed sleep. And remember, children grow during sleep. Growth hormones are released during good quality sleep. If you don't get to those good stages of sleep, it is going to affect your growth and development. That's a no-brainer. But I think in the past, everyone's been focusing on my kid having straight teeth and forgetting the more important issue, which is how are they performing in school? What is their sleep cycle like? What's the airway like? Do they snore at night? Do they sleep with their mouth open? Are they a restless sleeper? The sort of questions I ask. Number one, is it hard to wake your child up in the morning? Number two, do they suffer from daytime somnolence, where they're falling asleep at lunchtime, etc., etc.? Number three, how long does it take for your child to fall asleep? Because it's not just sleep disordered breathing that causes these sleep problems. It could be restless leg syndrome, narcolepsy, etc., etc. So I think, having a child evaluated if you see any of these symptoms is an important thing, and it's a non-invasive investigation. It's an overnight sleep study that gives you that rating, that AHI or that RDI, and that's a good start. So if you can go to your orthodontist saying, here's my sleep study that's been ordered by my primary care physician or the child's pediatrician, and it shows that my child has sleep apnea. And now I want your opinion on whether the narrow jaws and the crowding would improve or impact on that sleep apnea.
Okay. Would you support a ban on headgear or informed consent on headgear, mandatory informed consent that this could impact your kid's airway?
I think informed consent is very important. I think every parent needs to be told, based on current evidence-based literature, of the pros and cons of any treatment that's offered. As I said, I haven't used a headgear for about 15 years. Now let's define the word headgear. Some people think headgear is anything applied to the face. The term headgear is termed retractive headgear. That's what I'm dead against. I use face masks, which in a form are headgear, but that's to do the opposite. That's to bring the jaw forward. So in a child that has an underdeveloped maxilla, where the maxilla is set back, we use a protraction face mask to pull that jaw forward, which helps the airway and helps with facial mask. So that's still a headgear. So I think you need to be careful with your wording, and I think the wording should be, we'd want to have informed consent for parents who are offered retractive headgear.
Got it.
I think that's an important terminology. Yep.
Okay.
And retractive headgear is always what you see on cartoons and movies. If you look at Finding Nemo, that's that retractive headgear. If you look at Ugly Betty, it used to be called cat whiskers. And what I don't like about it, it's heavy forces, orthopedic. We're talking sort of 600 grams of force. And its anchor point is the neck. And if you speak to chiropractors and physiotherapists, what negative effect that can have on the vertebrae and the neck, and sometimes encourage. So the classic patient who has airway problems that are not diagnosed and then put into retractive headgear develops this forward head posture like this. They're compensating for the forces they've had here. They're trying to open up their airway, and they end up with a lot of lower back pain. So I get a lot of referrals from chiropractors and physiotherapists, again, for these people who've had the retractive type orthodontics. Yeah.
Interesting. Any last message you want to give to the parents? If there's one thing you could tell them in one sentence that they take home, what would that be?
I think don't wait till 13, 14 to take your child to an orthodontist. Again, look at 7 to 9. Secondly, work with someone who understands child's airway and their sleep cycle, and ideally work with someone who's at least going to try the non-extraction approach.
Okay. Thank you so much for your time. I greatly appreciate that.
Well, thank you. I'm sorry this interview had to be scheduled a few times, but unfortunately with the internet coming in and out all the way from Australia to where you are and patient scheduling, but any further help I can be, and if patients want to ask questions, if you want to leave my email, I'm happy to answer them when I can. It's just info@derekmahony.com, info@DEREKHNY.com.
Dr. Mahony, would you please repeat that? The connection kind of cut out when you were giving the email address.
Sure. If parents would like to get further information, they can contact me via my email, which is info at derekmahony.com. DEREKMAHONY.com.
Thank you. I'm sure you'll be getting emails.
Okay. Thanks for your time.
Thank you for yours.